So my name is Stacey Orangi. I am a research fellow from KEMRI-Wellcome Trust, and I'm glad to be moderating the next session. That follows well from our previous discussions, where we'll be having three presenters presenting findings on the cost of zero-dose focused delivery strategies in urban settings. So we'll have a lineup of three presenters instead of the four that are listed on the agenda. So that will give us more time for discussions afterwards. So to start us off, we have Hadiza Salele. She's an associate of gender programming at the Clinton Health Access Initiative. Hadiza will be presenting on the incremental costs and impact of evening and weekend vaccination sessions, lessons from implementing the zero-dose preparation reduction operation plan in Lagos State, Nigeria. So welcome, Hadiza.
Hello everyone, good morning and welcome back from tea break. As mentioned, I would be taking the presentation on the incremental costs and impact of weekend vaccination sessions, lessons learned from implementing the zero-dose operation plan. So by way of introduction, I think Florence earlier highlighted the high burden of zeros that we have in Nigeria. According to the last rolling estimate, the first one that was just released, we have about 2.1 million zero-dose children. And by definition, for Nigeria, zero-dose are children between 12 and 23 months who have not received the first dose of Venta. And a lot of data sources were used to prioritize 100 LGs in Nigeria out of the 774 that we have. So LGs are like districts, and out of those 100 LGs, we have two situated in Lagos states with highest burden of zeros, and those LGs are Alemnesh and Ikorodu local governments. Alemnesh is one of the highest populated local governments in Lagos State, with a population of about 2.2 million, and then Ikorodu has about a population of 1 million people, and we can also see the number of under one children and also the number of zero-dose children in those two local governments. The zero-dose reduction operational plan implementation started last year around August, and activities to be implemented included on leadership and governance, service delivery, demand generation, supply chain, and data management. And the implementation of Z-Drug is one of the three interventions that are implemented in the country, alongside gender mainstream and also the zero-dose learning form. So to now dig deep into the weekend vaccination sessions, why did we want to introduce the weekend vaccination? Because these two LGAs have a high population of working class women, also women who go to the markets. 3 out of 5 women in Lagos State are working class women. During one of the meetings that we had, an LGA allied officer mentioned to us that she went to her facility and there was a mother who was trying to rush to work, and she was begging her to ask the workers attention, and that was one of the reasons why they introduced the weekend vaccination session, so that they can reach such mothers. In Lagos State, there are 2 categories of health facilities based on the number of hours that they are providing these weekend sessions. There are facilities that are providing selected hours, which is 6 to 8, and these sessions are provided only on weekends. And to provide these sessions, they require 1 to 2 vaccinators. Most facilities require 1 vaccinator, 1 recorder, and also 1 community mobilizer who supports to mobilize women to the facility. And there are also those who are operating the 24 hours services, and they only require rotating the shifts for their healthcare workers to be able to provide those weekend sessions. So what did we do? We wanted to understand how many children are reached through the drop, how many additional children are we able to reach, and also to determine if those weekend vaccination sessions are cost effective. And we also employed a qualitative methodology to get insight from the healthcare workers on the best practices, the challenges that they experience in providing those extended sessions. We collected administrative facility data from these health facilities, about 4 health facilities, and we also collected the cost data from the Zedro budget costing and utilization data templates. And we also computed the incremental cost per dose of vaccine delivered. And we also tried to calculate the adjusted and the non-adjusted cost. And why this is important is because these zero interventions were not only done to reach zero dose children, they also reach other children, especially with measles vaccines, rota vaccines. So we also wanted to know when those funds are stretched, what is the cost per dose delivered. And the interviews were conducted with the local government immunization officers, the facility in charges, as well as the immunization providers. So overall, the Lagos State government with support from Gavi spent about 154,738,000 for the implementation of all Z-drug activities. And they were able to reach 1,662 more zero-dose children, and that culminated to a incremental cost per zero-dose child reach about $92.1. But when that cost is adjusted to include all antigens delivered during the provision of those services, that significantly reduced to about $4.26 dollars. And we can also see some of the cost comparison with other studies also conducted. But unfortunately, we're not able to find many studies conducted in Nigeria for us to be able to generate context-specific comparison in the country. And we can also see from this chart how the number of total 123 coverages increased when the drug was introduced. So from January to June 2024, there was no drug implementation, and the maximum penta coverage seen was about 60%. But we can see how the coverage is increased even more than 100%, especially because of some of the denominator issues that we have with measuring penta. But there was also a stock out of vaccines that led to the reduction in the number of children reached. When it comes to the incremental cost for Z-drug, specifically the weekend sessions, $1.36 were spent to reach the children. But this was adjusted to also include antigens. When it's not adjusted, the incremental cost is about $4.23 per zero-dose child reached. And comparing this with other studies also conducted, we saw that when adjusted with all antigens, significantly lower than what we saw elsewhere. So some of these key findings from the stakeholders, and we also tried to weigh some of the results here based on what we heard from the healthcare workers. One of the key things that they mentioned is that weekend vaccinations are complementary. They are not to substitute fixed sessions or outreach sessions or any other immunization session that is conducted, but instead it's to complement what is already ongoing and provide equity in reaching market and working class women. And the facilities also work to ensure that vaccines and other supplies such as syringes and the vaccines themselves are available in the health facility in such a way that they don't turn back line because they are not able to get access to vaccines. But one issue that they face is that in efforts to reduce the wastage rate for vaccines, they had to reschedule some clients so that they don't open some vans and they're not able to finish them. So you have to reschedule them to attend the sessions during a work day. And then health talks was also used in increasing awareness in the facilities, but they also experienced some significant challenges. I think everyone we spoke to mentioned the human resource gaps. We know that this is a very key issue in Nigeria, but it led to healthcare worker burnout because they had to go back to the health facility after they have finished providing the services during the workday for them to be able to provide these sessions. And one important thing is the demand generation that was not sufficient. Uh, Most healthcare workers also mentioned that if these sessions were conducted with more vaccinators and more demand generators, they'll be able to reach much more children. So some of the key limitations, and the first one is really important because in some of the health facilities, because they are expected to report weekend vaccinations as well, that's the perception that they have. We're not able to decide which ones were provided during workday and which ones were provided during the weekend. And that hindered our ability to be able to generate the data that we can use for weighted vaccination estimates. And then another key issue is the lack of robust country-specific costing data, which also significantly poses a challenge to generate meaningful comparison. So, in conclusion, in conclusion, we believe that weekend vaccinations are cost-effective, but it's very important to address the human resource challenges that we have, and they also complement other immunization service delivery approaches, and for us to be able to reach more and more children, it's important to ensure that weekend vaccination is integrated into the immunization policies and plans. And and there are also different parts that stakeholders can play to be able to implement this. One, for IPs and development partners, is important to support governments, while for the health managers and implementers, it's critical to ensure that these weekend vaccinations are integrated into the service delivery models, and to also increase the investment in human resources for health and innovative financing, and for policymakers to create very standardized guidance document and normative documents to support the delivery of weekend vaccination sessions. Thank you for listening.
Thank you very much, Hadiza, for the clear and excellent presentation. So our next speaker is from Ethiopia. Alemnesh Angelo is a senior analyst at Clinton Health Access Initiative in Ethiopia, and she will be presenting on a costing study of interventions to improve routine outreach to zero-dose children in Addis Ababa.
Hello everyone, my name is Alemnesh Angelo. I am from the financing team in China Ethiopia. I will be taking you through the posting study on CDLA, the Zero Dose Learning Agenda intervention to optimize outreach in Addis Ababa. So, sorry about the technical issue. So, just to give you the brief highlight about the Zero Dose Learning Agenda, the ZDLA project is being implemented across 6 countries in Africa and Asia. And what's peculiar about ZDLA is that it's leveraged the human-centered design approach to targeting and addressing zero dose children. So it starts by identifying the drivers or the root cause of zero dose, and then moves on to creating or co-creating solutions and interventions with caregivers, stakeholders, and government in the facility level, and then build so further by testing those interventions and implementing and further improving those interventions through continuous learning by doing. So this interactive process makes the ZDLA approach unique, and its ultimate objective is to ensure government uptake and sustainability of the environment. So, Ethiopia is one of the six countries implementing ZDLA, and it's known for the ranked third in terms of zero-dose children, and currently working with partners like Gavi, BMJF, and ELMA in addressing zero-dose and implementing zero-dose project in 15 districts across 5 regions. Specifically on the zero-dose learning agenda, the target is to implement this intervention in 3 sites, representing different contexts. For instance, for Addis Ababa, it's an urban slum area, and for Afar, it's a pastoralist area, and for the agrarian area in Oromia region. So our focus for this today's discussion will be the Addis Ababa implementation, because the interventions were implemented January 2025, so we'll be focusing on that. So for the Addis Ababa, the site is located in one of the 11 sub-cities. It's called Nefas Kilaftu sub-city, and the health center is where the District 1 health center. So what were the interventions implemented in this site? So the co-created interventions with the caregivers and the government partners were prioritized, and they are 3, but they are not independent, they are complementary to each other. So for the API managers group, the intervention was to mobilize the resource to ensure availability of resource for the outreach service, and for the health center side to allocate and commit resource, HR and other required resource to conduct outreach service, and from the community side was to establish an outreach at the community level, so which required initial capital investment from CHI side to upgrade the site to make it ready for outreach service delivery. So these 3 integrated, interrelated interventions ultimately aimed at tackling or addressing the issue of access to vaccination service. So having this as a background, how do we approach the costing study? So our objective is to assess or estimate the incremental cost of reaching the zero dose at the vaccination site or at the intervention site, and to analyze the key cost drivers for that as well. So this will help us to inform determining the budget and envelope and planning for the future. So with this objective, the approach or the methodology that we adapted is ingredient-based costing, and we looked at the payer's perspective and looked at the implementation retrospectively. So based on that, we used a structured data collection instrument. We tested it in an adjacent health center, and we tried to complement that with observation on the outreach sites. And in terms of the costs, we have considered both the financial and the opportunity cost to see the overall resource requirement or the value of resource required to deliver or to reach zero dose. So what do we have here as a result? So this slide depicts the typology of the cost of providing those, delivering those interventions per month. So the financial cost of delivering or operating those intervention estimated around $65 per month, and the opportunity cost is around $155 per month. So if we consider the value of the technical support or the program management, we will have additional cost around 171. That will make it the total economic cost of providing or delivering those intervention around 390. So we see the difference or the gap in the financial cost and in the economic cost, because the intervention relies heavily on the available or existing resource, human resource, as well as volunteers, especially for the demand creation, for the demand generation. The community engagement is key, so we value the value of those the community participants. There's also investment on the renovation that has opportunity cost implications, and there were donations provided by the facility, so we also factored all those. That's why there is like a huge difference between the opportunity cost and the financial cost. And when we look into the cost categories, which are the key drivers for the financial and for the opportunity cost, we see that the per diem and the cost is a key driver, accounting for almost half of the financial cost, and followed by the renovation cost. This is actually a one-time cost, but since it's a capital investment, we have amortized that. So still it takes a significant part, about 28% of the cost, and then followed by a social mobilization. So these three categories of costs account for 85% of the resources that the financial cost. And whereas in terms of the economic cost, still the human resource cost, especially from the technical assistance or from the program management, is a key driver there, and it's also followed by the renovation cost for the site. So having this, then we moved on is to estimate what would be the cost of reaching the reduced children. So one thing that I wanted to highlight here is that we have not included the cost of vaccines and supplies. So this is more of a delivery cost. So and what we see here is in terms of cost, the incremental cost of reaching zero-dose children. Zero-dose is defined as a child with the age between 1 year and 5 years who have not received Penta-1. So with that definition, we estimated the overall economic cost, incremental cost, around 48.8 USD. And from this, if you look only at the financial outlay or the financial commitments, it's around 8.1. And when you look into the denominator and when you increase other antigens or children who received other vaccinations, then this cost goes down a bit by bit. And for instance, if you consider both the Penta and measles provision to the children, the cost of delivery goes down to 12.3, almost $30 per child. So the overall cost per dose for that specific outreach site is estimated around 5.8 US dollars. So when we compare this to the routine cost of delivery, it's expensive. According to the study shared by the Immunization Economics, the delivery cost is about 1.6. So you can see there is a huge difference, in huge gap there. And the reason being is that this is an urban area which typically has a high immunization coverage, more than 85%. So reaching those unreachable or a very small target of the population requires additional commitment and additional resource. So that's the estimate. So wrapping up, what are the key insights from this phase 1 study is that there are cost differences when we consider the opportunity and other costs. There is significant difference. That shows the indication that how the current implementation relies on the existing resource. So which also important for informing the resource requirement and for budgeting as well. So in terms of the cost drivers, still here the paradigms and renovation costs are key, but depending on the context, if in some area, if renovation is not required, I think that will make a significant difference in terms of the amount of resource required to reach zero-dose children. In terms of, again, the cost of vaccinating or delivering vaccine to the zero-dose children, it's expensive compared to the routine vaccination. So that means if we care for equity, if we care to reach every children, so we have to make additional investment, because those at the age are not coming in or are not being able to vaccinated with the current or with a similar level of investment. So additional investment might be required there. So what we can, this study tell us about the effectiveness of the intervention, I think this requires further study and further generation of evidence into the return on investment in this aspect. So I thank you so much for your attention.
Thank you very much. So we'll now welcome our last presenter, Christina Banks from ThinkWell. She's a technical advisor at ThinkWell, and she'll be presenting on the costs of immunizing zero-dose children through additional outreach sessions in Lagos, Nigeria.
Thank you.
So this study is a part of the study which Dr. Florence had already started presenting on this morning on the state of Kaduna. So I'm going to share our findings from Lagos. Like our study, our objective was to estimate the cost and effectiveness of outreach strategies to reach zero-dose and under-immunized children in Lagos. I won't repeat all of what Dr. Florence has said regarding methods. I'll just highlight two different points. In that, as Hadiza mentioned, there were only two priority LGAs in Lagos, so we sampled both of those, and we did purposive sampling of local council development areas in collaboration with the state MOH to get a different set of settings. And we also captured costs during a typical month at the point of data collection, which was February 2025 for us. So from the two LGAs in Lagos, we included 15 facilities. 9 are part of the ZJOB initiatives that Hadiza had introduced, and 9 were in urban areas, with the others classified as being rural facilities. In terms of the differences between those and the kind of root causes of zero-dose prevalence, all of the urban facilities reported that cultural or religious beliefs and a lack of awareness was one of the main causes of zero-dose prevalence, while in the rural facilities, it also came up, but also transport issues in the form of poor road access and a lack of transport funds for beneficiaries to attend sessions. As Hadiza mentioned, ZJOB activities started being organised kind of earlier in 2024, with implementation happening between July and February 2025. So in the facilities we included, before there had been generally one outreach session per week. After the implementation of ZJOB, this went up to 3 sessions per week, with these 2 additional sessions on kind of days which weren't typically used for immunisation before, such as weekend days. And respondents also reported travelling further during these sessions and during social mobilisation for these sessions to try and spread the word and reach some more children. So if you look at the difference in dose numbers delivered on average per month before and after the implementation of ZJOB, you can see that at both ZJOB facilities and non-supported facilities, there was a general increase. with this being a higher degree at the Z-job facilities, of 29% compared to a more modest 12% increase at the non-supported facilities. And when just singling out the urban facilities, we saw that at the Z-job facilities the rate of increase was slightly less, and at the non-supported it was slightly higher. So we saw that during the Z-job implementation, the facilities reached more new children than other facilities, although this wasn't relative to catchment population. So in this first graph we can see the difference between the average doses delivered per month at Z-job and other facilities. So at Z-job facilities we saw around 1,880 per month compared to 898 at non-supported. And at the urban only we saw just over 1,300 at the non-supported and over 2,000 at the ones which are implementing these additional sessions. When we brought the catchment population into this to see are Z-job leading to more children within the areas being reached with 10 to 1, we saw that within Z-job there was kind of fewer 10 to 1 doses delivered on average to person in the catchment population compared to at the other non-supported facilities. So most of the additional children who were reached by the Z-job facilities were reached through the modality of outreach. So you can see that during kind of both strategies, so either at the facility or through outreach, there were more new children reached. And also urban facilities delivered a slightly lower proportion of 10 to 1 doses through outreach compared to the rural facilities. So then moving on to the cost of the sessions. So we saw that the cost of delivery was higher for our outreach than for facility-based. This was primarily driven by the incentives for staff and the transport costs. We saw that outreach costs tended to be slightly lower at the urban facilities than overall. And you can see here for outreach the difference between the other facilities, which were 13 cents per dose delivered, and the Z-job facilities, which was 36 cents per dose delivered, and that was for doses of any antigen. Driven by that, the incentives given for these additional Z-job sessions were substantially higher than were for regular outreach. So then splitting apart the regular outreach sessions, which continued to happen once per week, and then these additional Z-job sessions, which happened twice per week, we can see that the cost of these Z-job sessions was more than 3 times that of regular outreach. So the Z-job sessions were also slightly lower at the urban facilities. A big driver for the increased cost of dose of these Z-job sessions was a lower delivery volume of children reached. So you can see that when splitting apart the cost per dose per any dose delivered is significantly higher for the Z-job outreach. And when you take into consideration an average of 152 doses delivered at a regular outreach session to just 32 on average at these Z-job outreach sessions, you can see there's many higher costs, and they're split over a much lower number of doses. So the key takeaways from our study is that the Z-job support did increase the number of vaccines delivered, as well as the number of additional children reached with 10 to 1. That the increase in the number of outreach sessions resulted in lower delivery volumes and therefore a higher cost per unit of delivery. And these sessions reached very few additional children with 10 to 1 compared to regular outreach, but at a much higher cost, which questions the suitability of these interventions to address the root causes of zero dose prevalence in those particular areas, namely cultural beliefs. And that's all, thank you.
Thank you, Christina. So I'll now welcome all the presenters to take a seat at the front. And we'll open the floor for questions, comments. Before you comment, kindly request to briefly introduce yourself, your name, and your institution. Any questions or comments?
Thanks very much. Thanks for the presentations, Brendan Pesca from UNICEF. My question goes to the last presenter, and also in her presentation. So Z-drop seems to, even from the first slides, you see that there's an issue in terms of vaccine availability at the facility. So Z-drop seem to have been addressing the supply side of the zero-dose problem, yet we seem to notice that most of these communities also have a demand issue. So was there anything done to address the demand? Because from the presentation I seem to have seen more supply side action. And probably that's what you were implying in the last comment around part strategies. So I'd like a comment on what was done for demand side.
Thank you so much. My name is Fideli Swamara from Heidelberg Institute of Global Health. Maybe just to follow up to the question and to specifically ask, because in your problem statement you talked about cultural issues being one of the reasons why we have high zero dose. However, we may have missed in your presentation, was there any intervention to address this for the purpose of for our learning purposes? And also to the same presenter, you highlighted in your methodology that there were routine outreaches, then specific zero dose outreaches. What was the difference between the two?
Thank you. We'll take a question from Yoga.
Okay, thanks very much, and thanks for all the very nice presentations. The first question is that we have two presentations on Z-drop from Nigeria in Lagos, and the first presentation came up with $34 per dose, and the next presentation came up with $1 per dose. And so I guess I'm interested to kind of figure out and unpack what the differences might be due to. And is it a difference in methodology? Is it a difference in maybe placement of the facilities so that the density of zero dose is different? What might be accounting for that? And then I had a question for Christina, which is, you were almost there. I thought maybe you would tell us what the cost per zero dose trial was, and is there a reason for not withholding that information? Okay.
Thank you. I think we'll take one last question here.
Hi, my name is Anya Khan from Impetus. I think there is a differential here between costs for interventions that are targeting demand side or cultural or issues related to intent compared to those related to supply and system level inputs. Any perspective you could offer as to how you account for that, and what could be our consideration for interventions that deal for the former?
Thank you. So we'll take those 4 questions first.
Sure. So I'll start with the first question regarding the what's been done to kind of increase demand. So we saw with the Z-drop sessions, they also implemented additional social mobilization sessions, usually ahead of every Z-drop session that was happening. So health workers would go out to the area that was going to be targeted, meet with community leaders, sensitize the populations to what was going to the session that was going to happen, and those costs were kind of part of the overall delivery cost for the sessions. and although they did organise the additional sessions, it came a lot up frequently in the kind of comments from health workers that this still was insufficient and more materials were needed, more incentives were needed for community volunteers who were helping with sensitisation, more funding for printing, for media, all kinds of means of increasing demand. In terms of the routine outreach and the C-Drop outreach and the difference between the two, so in some cases it was a similar kind of implementation, just on a different day, where immunization hadn't been offered before. In other cases, there was a kind of efforts to kind of travel to different places, to try and travel further, to and conduct social mobilization in different areas to try and reach new kids. In terms of kind of our differing kind of results, we know that one of our facilities is a crossover from both of our studies, but we definitely want to kind of get our heads together and kind of dig into our findings and like what could have driven these differences. And to open your question regarding the zero-dose children reached. So for our facilities, we really struggled with data availability for the number of zero-dose children reached. Out of the 15, there were 3 which gave figures. 2 were just for the additional Z-Drop outreach sessions. 1 was for regular sessions. So it's been tricky to kind of to draw conclusions from that so far, but it's something we do want to examine kind of further in our analysis.
Just to briefly add on the question regarding cultural belief, just knowing Lagos State. So, for example, those 2 local governments have a high migration rate. There are people moving into those locations to settle from different parts of Nigeria, from northern Nigeria especially, and we typically come across issues raised by healthcare workers that they have issues with the health-seeking behavior with certain communities within those LGAs. So I think that could account for the issue on cultural belief that Christina mentioned in her presentation.
Thank you for the questions. I will review on the question regarding the interventions that target intent. So, in terms of like the current focus for Addis Ababa, the key barrier prioritized by the study interactive process with stakeholders is access to vaccination services. However, this doesn't mean that there is no the issue of demand generation or a barrier related to intent. So the approach that adopted is to leverage the community members who have great influence among the community members and leverage they call the corridor leaders, like representatives from a certain group of village. So these representatives, they do sensitization on vaccination, and they inform caregivers on the potential benefits of the vaccination, and they also inform the adverse effect about the vaccination, so that those caregivers are well prepared to deal with the whatever happens after the vaccination. So that are part of the intent, even though it was not emerged as a key barrier, but it was silently part of the intervention. So we also try to capture the time of those volunteers who spend time in advocating and convincing their community members to bring their children to the vaccination site. So that was how we tried to complement the barrier, the access with the intent.
Thank you. I think there was an additional comment from Florence on Nigeria.
Thank you very much, Christina.
So I want to respond to the wide disparity between our findings and the other finding from Nigeria, the same state. I think it has to do with methodology, because we did bottom-up costing. I'm not yet sure of the method they use in the other costing. Maybe it's a project something. Then we also considered for this presentation facility-based costs, where the actual cost they incurred for going to outreach sessions. So the administrative costs from state and maybe national, we are not considered. Thank you.
Thank you.
Hi, I'm Brian Padman from Johns Hopkins University. I have a comment for the community and the speakers and a question. The first comment is I really like the presentation that was done by the second presenter of the financial costs side by side with the economic costs broken down by category. Similarly to the first group, there was another presenter, the last one who presented in the first panel, who did the same thing. I think this should be standard practice. It's really informative. And so what was shown in that was that HR costs and volunteer costs were 0% of the financial costs and 17% of the actual economic costs because of the donated time, or somebody else, some other budget was paying for those HR people, but this program intervention was using them. Could perhaps that be the difference between some of the estimates that were found in Nigeria, how you calculated the costs based on those things that were donated versus not, and what do you think about the sustainability of these interventions when we're relying so much on donated time?
Thank you. We'll take 2 more questions.
I have a similar question. Thank you very much to the second presenter. My name is Maria Vericchio and I work for Gavi. With reference to the financial versus economic costs, one of the very interesting findings was also the 44%, the cost driver of TA time at a 44% rate of the economic cost. And I wanted to ask the presenter to maybe unpack this a little bit. What did you consider under that technical assistance? And whether you have any other comparator data with the rural setting or with the other economic cost estimates that you provided from, I think, Uganda and India with respect to the TA type. Thank you.
Thank you so much, Paulo Lee, WHO Info. My question is, since we are talking about strategies in urban setting, and also this morning highlighted that access is more major issue, whether any of these studies look at extending the time hour of facilities in urban setting, where parents can go and get the services behind the normal working hours since they are working. So maybe this could be one of the strategy to look at, and maybe it being more cost effective than going outreach. But still, we need to look at that. Thank you.
Thank you. Any more questions or comments? I think I'll just add one question for Nigeria, the weekend vaccination strategy. I just wondered whether it also, was it just immunization on that weekend, or were there other services that were being integrated? And I was also just curious on the proportion of children who were 0 dose versus under-immunized for the weekend strategy. I'll take one last question from Mark, and then we'll get the responses.
Thank you. Thanks for all the presentations. Just a sort of general, broad question, because thinking over both this session and the one this morning, which were both really interesting, it feels like we've had such a broad range of costs per, 0 dose child reach, ranging from $1 something to hundreds of dollars. And I know some of this is, there are different settings, different populations, and different methodology was used, but I'm wondering, you think there might be the potential and the usefulness to actually, bring everyone together and say, if we use a standard methodology for our costing, can we tell to what extent these differences are driven by population level differences, so urban versus rural, populations with different characteristics, and to which extent they're driven by intervention characteristics? Because if some interventions are a lot cheaper than others but still reach the same children, then these are the best buys, right? That's maybe taking a step back and being able to work that out. And I think that will need all of you, because if someone comes in and does a systematic review after you publish the paper, they won't be able to find enough to standardize all the methodological differences.
Thank you. Over to the presenters. Your reactions.
Thank you so much. I will just start and then the others will continue. To start with the last question, I think Christina and the rest of the team is actually working towards that, towards conducting a costing synthesis of different costing work that has been done. I think in Nigeria, I'm not sure which other geographies they are also planning to cover, but I know that they also have plans to cover Nigeria. But I completely agree that that is really necessary, especially because of the differences, the significant variation that we're seeing in the numbers, which is largely also due to the methodological differences that we have. For example, the number of facilities that Christina and her team covered is much higher than the number of facilities that we covered in our own. And also I think the cost elements that were included in the different costing studies were also different. So yeah, I completely agree on that particular comment. And then regarding the question on integration of other services, so in some of these facilities, they were already providing some vaccines, especially at birth. So they provide OPV0, HEP0, and other vaccines. So they're also providing those services, and also maternal health services in those facilities mostly. We also try to ask if they are providing other services apart from these, and we discovered that most of them actually prioritize providing just immunization and maternal health. And in some few places, they also provide nutrition services to children. There was also another question about percentage of proportion of zero-dose children versus the unimmunized. So particularly for the weekend vaccination sessions, we saw that it's mostly an access point for DPT1, DPT3, and then the vaccines at birth. But other vaccines are provided through other service delivery approaches. For example, they highlighted how the market storms were particularly important for reaching children with measles vaccines. So I would say that for the weekend vaccinations, zero dose and then Penta-3 as well. Yeah, I think I will stop here for the rest of the.
I really see the value of having consensus on the approach, costing approach, and what variables or what type of cost to consider, because if we have that consensus and that methodology that guide the exercise or the costing study, I think we might have more comparative study, and that we can also compare the outcomes of those study and get more insight from that. So with the current fragmented and very isolated different approach and methodology, that might not help us to move forward. So having the consensus or building that consensus around the methodology and the approach, I think will have a great value for the work that we are doing and for the future as well. I wanted to reflect on the questions related to the sustainability, interventions or projects are sponsored or financially supported by donors, and we see these days that those kind of support are not going to continue forever. So we have to start thinking about how those supports can be sustainably sponsored or financed locally within the capacity of that country. So one approach for that would be integrating with the service that's currently being provided and leveraging the existing resources within the public, within the health sector. So that would, to some extent, contribute towards sustainability. But I think it's one topic area that needs to be very much investigated because it's becoming critical these days. In terms of the technical assistance or the program management time, so since we looked at the intervention retrospectively, the approach we followed is we tried to get the time spent or allocated for providing support and implementing those interventions at the facility and at the outreach site level. So it was a retrospective approach, and we interviewed or gathered the information from individuals who are involved in the implementation of the Zero Dose project individually. So we have not got the opportunity to compare with other country costing study. We have seen some estimates from the costing catalog recently released. We saw that the cost of reaching zero dose is around $64, if I'm not mistaken, per child, and the cost of reaching under-immunized children is around $70 US dollars. So, but we didn't have the specific context and components that were built into that. So, but I think having this consensus that was raised earlier will help us to shape how those cost components, whether it's technical assistance or staff salary or other component, should be treated and how it's considered. That kind of consensus will be important going forward. Yes, I think.
Thank you. So first of all, on the bringing together of different data points, examining different methods, Laura's actually going to be sharing at the end of the day a kind of like a high-level synthesis of various data points on the cost of reaching zero dose children, and explaining kind of more about what we've done on that. To the point regarding the economic cost, we absolutely agree that is a very important component for sharing, and in our study we also did a full kind of costing of labour, volunteer labour, use of cold chain equipment, which will be kind of sharing our other findings. In terms of kind of explaining differences between the Z-drop versus the regular outreach strategies, it wasn't a kind of a great driver. There wasn't a hard and fast rule of teams were bigger during one kind of strategy than the other. It was a very mixed bag of sometimes there being more at regular outreach sessions versus sometimes teams were a lot larger for Z-drop. But yeah, it's a very important component, and we'll be sharing more on that.
Thank you. Any other questions or comments from the audience?
Yeah, I think one of the important drivers of the differences in the estimates that we're seeing is the volume. And it seems like an obvious thing that in some cases we have, well, it's difficult to measure the number of zero-dose kids in a lot of contexts, but when we can, the volumes are quite different. And I think this goes to Brian's question in the first session, which is in an area where you have maybe a large density of zero-dose kids, you come in and you have a strategy that actually reaches a large number of them. If you were to measure again at some point in time a little bit later, probably your cost per dose would be very different, right? Because the pool has shrunk, so your cost per dose would probably increase. And we don't really, with these kind of snapshots in time of our different estimates, we don't really know the dynamics behind what's going on in terms of reaching zero-dose kids. And I think only understanding that can we think about scalability and sustainability. So I think there's probably a lot more work we have to do in terms of that.
Just maybe a minor question, but has there, I'm Disha from Gates Foundation, India Country Office. So has there been any thinking done from the beneficiary point of view, as in how much is being, what is the cost being incurred from the beneficiary perspective?
Thank you. Any more questions or comments? Okay, one.
Thank you. My name is Vincent Omondi from Clinton Health. I'm based in Kenya. So my question, I'm still curious with the integration services, especially the extended services over the weekends. You talked about already additional services happening at the maternity, the birth doses already are happening before the extended services. But I'm just curious to understand during the, whether there were any additional opportunities, especially at PHC level, that do not offer maternity services for the birth doses. Are there any values for the nurses that were offering the vaccinations alone on the weekends, especially looking at these facilities that are understaffed during those sessions? Thank you.
Thank you. I'll hand over to the presenters for their reactions.
Sure, perhaps I'll just talk briefly to the question regarding from the beneficiary perspective. So an element of our study was taking into consideration incentives that are given to caregivers and beneficiaries. In Kaduna, 2 of the LGAs we sampled were part of the new incentives program where beneficiaries receive incentives and 2 were not, which is going to kind of factor into our later kind of sub-analyses. In Lagos, there was no incentives offered, but we did note that the health workers did say that offering these would have increased attendance. We also collected information on the costs incurred and the distance or time spent to get to facility versus outreach sessions from the beneficiary side. So we'll be including that in our kind of our next analysis steps as well.
vaccinated, but now it's nearby, so I don't have to use this, and I don't have to incur any additional transport costs. So even though we have not explicitly captured their response in a structured way, but we sense that this intervention by creating the outreach service at the nearby facility is to some extent decreasing the burden from their side.
Thank you. I think the situation is also the same thing in Nigeria, where women bear the transportation costs, especially in low-income households. They tend to prioritize vaccination, where we see there are programs currently running where incentives are provided to women to take their children for immunization in a number of states in Nigeria. But one issue with that is that these incentives are not provided to women, to their zero-dose children for immunization. It only covers those that actually follow the routine immunization schedule. So that's one challenge that even healthcare workers are actually experiencing with sensitizing women to take their zero-dose children, because they always compare that their counterparts who are taking theirs for routine immunization and are receiving some incentives while they are not. So that's one issue, for example. But I know that we also have another team that is working on the cost to the client in Kano State, and they will be sharing some of those findings during the main conference. And then with integration, I think there are a lot of opportunities there, but one unfortunate situation that we have in Nigeria is the healthcare worker shortage in those health facilities. That these healthcare workers, even though they are given some stipends, they get about $15 to go to the health facility and provide those weekend sessions. But they also complain that they want to rest even though they are given, those stipends. They would also, like it if other healthcare workers can go to the weekend while, they focus on other work that they can be focusing on at home. But there's a lot of opportunity for integration there. Any service, for the child, including nutrition, weight measurement, treating children with severe malnutrition, and even family planning, especially because the mother is, going to the health facility for her child, so why not also reach her, with family planning, for example. But that will come with other costs as well, to be able to provide, the services in the health facilities. I think that's all. Thank you.
Thank you very much. Any last questions or comments from the audience? We have a few more minutes. Okay, I don't see any more hands. So I think for me, my key takeaways from the discussion have been the importance first of, we have this emerging evidence on zero-dose costs, which is very important. But now we also need to think about comparing the different the cost of the different delivery strategies with similar methodologies from different settings, but also the importance of presenting disaggregated costs so that we're able to explicitly see what the different cost drivers are, and also to bring out the differences between the financial and the economic costs, because that helps us to see the effect of things that are donated, and that builds on to sustainability discussions. But beyond that, there is still more work that needs to go into place to understand the dynamics in the different settings over time that would continue to inform discussions on scalability and sustainability of cost of zero-dose vaccination in urban settings. So I'll hand over to the presenters for any final comments and final words, then we'll wrap up. Over to you, Christina.
Great, thank you. Yeah, I'd just like to echo what you said about the importance of aligning our research efforts, aligning our methods, and then kind of using it to go further to understand the costs, efficiencies, and reaching more zero-dose children.
Yeah, I fully second what you said. So aligning with the approach and the methodology is important step. Just to reflect from the insight from our study, the cost of vaccinating zero-dose children could be higher or expensive compared to the routine one because, as I said earlier, the return on investment is not flat. The population, the mass of the population is, in terms of children, are reached through the routine campaign or the routine vaccination, whereas those marginalized one or very specific targeted populations group are not easily reached. For that, it requires additional resource, additional commitment because their lives matter, their health matter. So efficiency is a key, equity also another important point. So we need to balance efficiency with equity.
I think they have said it all. It's really important to align our approaches, our methodologies, so that we can get standardized and comparable results. But one thing that I also want to ask, just in line with what she said, is should we prioritize interventions just based on cost? Because even though some interventions cost more, but they need to reach a special or a specific group of people. So maybe that can also be a consideration because there is need for equity, for us to be able to reach these children with vaccines. So, for example, being a zero-dose child means that you have to spend more to reach that child, and you have to spend more than when you spend, conducting a routine session. So it's really important to also consider equity in, reaching other children as well. Thank you.
Thank you very much. So thank you all for the engaging and rich discussions, and to the presenters, thank you for your great presentations. I'll now hand over to Laura.
Thank you, Stacey, and thanks to all our